Thank you very much. It's now my great pleasure to introduce Dr. Rafat Abonour, who is the director of the Myeloma, Waldenstrom, and Amyloidosis program in Indiana University. Thank you.
All right. Good afternoon. It's a pleasure to be here to talk to you about thrombotic and bleeding complication of amyloidosis. I need to send a shout out to the late Merrill Benson, who was an active amyloidosis researcher and physician at Indiana University, and always taught me that liver bleeds, and I will never forget that. 28 years ago, we had the patients who had a liver biopsy and bled about 6 units of blood. So I respect bleeding, diathesis, and amyloidosis. I have nothing to disclose, but a disclaimer that I am not a thrombotic expert or a bleeding expert. I just see a few amyloid patients a week, and Jeff asked me, so I couldn't say no to Jeff to present this. So the question is, why do patients with amyloidosis bleed? And why do patients with amyloidosis clots, and how to manage these patients. So we're gonna have a quick journey here to try to discuss these things. Just a reminder that the blood has to stay in the circulation, and several components of the bleeding of the vascular system and the coagulation system have to work perfectly. You have to have an intact wall, active platelet, but not too active. You have to have the balance between coagulant and anticoagulant proteins, and you have to have a fibrolytic system that work when you get a clot. And all of these things can be affected in patients with amyloidosis. So the way I'm going to present this, 2 cases. The first one is a 58-year-old woman with AL amyloidosis presented with biatrial thrombosis while in sinus rhythm. The prior symptoms that led to the diagnosis were orthopnea, postural hypotension, epigastric pain, anorexia, nausea, vomiting. You heard all of these different sort of symptoms that can be difficult to lead to diagnosis of amyloidosis right away, like you heard from Dr. Mokhtar. Finally, because of the anemia, I think they were doing a gastric mucosal biopsy and an upper endoscopy. Amyloidosis was diagnosed and confirmed by mass spectrometry, just to make you happy, Dr. Mokhtar. So an echocardiogram was done, and the ejection fraction was 45%. The intraventricular septum was slightly enlarged, 12 millimeter, but a 32 by 17 millimeter mobile thrombus protruding from the left atria appendage was seen. There was some thickening in the cardiac valves and the atrial septums. And the atria were moderately dilated. And they saw some hepatic vein dilatation and some pleural effusion. So the question is, why do patients with amyloidosis have thrombosis? And you can see that the first 3 things is really related to the heart. Having a cardiac involvement is very important, from heart failure to atrial fibrillation to really newly kind of described entity that we have sort of appreciated is atrial myopathy. And I think that's very important to keep in the back of our mind. Obviously, the other 2 things is that nephrotic syndrome. We'll talk about that in a little detail. And I was talking to one of my colleagues here, Dr. Burrell, about the use of immunomodulatory drugs, and they're very effective, but they can increase the risk of thrombosis. This is a work that done by Nicole et al. To sort of summarize some of the publications on thrombotic event in the patient with amyloidosis. And these are several studies that have been published in the last 20 years. Some of them are old, as the one by Fang in 2007, and where showed the incidence was about 33%. But a lot of these thrombotic events were actually discovered on autopsy. But if you look at Capilla et al. In 2020, they showed the prevalence is about 7.6%, and they identify a risk factor to be atrial fibrillations, lower ejection fractions below 50, chest to VASC score above 2, and chronic kidney disease. Dr. Matarini and colleagues reported on 290 patients with TTR. Their incidence was 6%. So you can see that quite variations in terms of the incidence and the risk for thrombotic event. So nephrotic syndrome, you're all familiar when you have more proteinuria, more than 3.5 grams per day, and you have a lower albumin of 3 grams. It does increase the risk of both deep venous thrombosis, renal vein thrombosis, and pulmonary embolus that can be asymptomatic in most of the cases. But it's very important to remember that it rarely can cause cerebral vein thrombosis or atrial thrombosis. So why does nephrotic syndrome do that? Why do patients do clot? Because there is a reduction in the level of antithrombin 3, protein C, and protein S, and there's increased level of fibrinogen, clotting factor, and so leading to sort of imbalance of the clotting factors. And more importantly, there is also damage to the vascular endothelial layers, glycoglycic. So that damage lead to platelet aggregations and clotting. Obviously, we all familiar that patient with nephrotic syndrome will present with hyperlipidemia, their cholesterol running in the 600 and similar. So the question, does that lead to inflammations and further activation of clotting factors and increase the risk of thrombosis? And I think there's a provocative question whether treating the hyperlipidemia is very helpful in reducing the thrombotic events, and I'm sure we all have different opinion on that. Personally, I believe that getting rid of the amyloid and correcting the nephrotic syndrome, which can occur quickly, luckily is one of the organs that improve the fastest, may lead to correction of the hyperlipidemia. So how do immunomodulatory drugs cause thrombosis? It's not really well understood. So patient underlying health factors may play a role, but they can also increase the risk of production and activity of platelet, can increase the production of certain procoagulant factors, and does interfere with the blood vessels. And we all know about the Virchow triad. That's very important to have an intact blood vessels and hemodynamic stability. So basically, thrombotic event in systemic amyloidosis, mostly atrial thrombosis and CVA, which can be more common actually in ATTR than AL amyloidosis. And again, what lead to thrombotic event is both the atrial fibrillations and atrial dysfunction. And one of the things that really near my heart is that, I believe that sometimes our colleague in cardiology and the nephrologists are very eager to try to get rid of every possible peripheral edema, which is impossible when you have somebody with low albumin. So using diuretics aggressively will lead to, sort of stasis, and stasis and reduced turbulence will lead to thrombosis. So I think being too eager, to over-diurese these patients may increase the risk of thrombotic events. There are some studies published on basically the prevalence of embolic events in atrial fibrillation, and obviously we know that's a risk factor, but you can use the CHAD2 VAS score system, and the higher the score, the more likely you're going to see a thrombotic event, up to 11.1% in patients who score 5 or higher. Now the question is, how about the patients who are not on anticoagulation and in normal sinus rhythm? Is there a way for us to predict who's going to develop thrombosis? And actually, really doesn't. If you look at the patient in normal sinus rhythm, the higher the score, still maybe slightly elevated, about 3-4%, but it cannot predict compared to patient with atrial fibrillation. So you can't use that scoring system to help you. But I think we need to remember that patient with cardiac involvement, even without atrial fibrillations, are at measurable risk of getting a clot. So we should be sort of thinking about using anticoagulation in that setting, or obviously looking first closely to make sure that they don't have a clot by appropriate studies, beyond just the simple echocardiogram. All right, so let's move on to the other extreme of the we see in patient with amyloidosis. This is a 69-year-old male with basically restrictive cardiomyopathy, had an increased creatinine. They thought about amyloid, had a fat pad biopsy, and it was Congo red positive, and on physical exam had the loud S4, mild hepatomegaly, and this purpura. So the question is for you, and I think what is the reason for these patients to have this purpura? Is it severe thrombocytopenia, acquired factor inhibitor, absorption of clotting factor on amyloid deposit, acquired Van Willebrand factor deficiency, or cryoglobulinemia? Please vote. Do I need to push or? So I don't know if we have a voting. Okay. Did you get? Okay, here we go. Excellent. Excellent. So it seems the majority got the right answer. All right. So let's go forward here to the next slide. All right. Yeah. Are we? I think we're good. All right. So additional laboratory data obtained that had an elevated lambda light chain with an abnormal ratio. There was 8% lambda light chain restricted plasma cells in the bone marrow, mild anemia, and the patient had a prolongation of prothrombin time to 17 seconds and had a very low factor 10 activity of 7%. So what caused a patient with amyloidosis to bleed? A lot of different things. One of them is gastrointestinal involvement by amyloidosis, as we saw in this case, factor 10 deficiency, but also our colleagues in Boston have reported on several cases of other factor deficiency, including rarely Van Willebrand factor. And there's obviously the concern about renal failure leading to platelet dysfunction. And not to forget that our patient with amyloidosis do present, some of them, with autonomic dysfunction, and they are at risk of falling and bleeding because of that. In AL amyloidosis, bleeding is more common than thrombotics, and actually bleeding is more common in AL amyloidosis than TTR. So this is a study that tried to evaluate 337 patients with abnormal bleeding and saw that 28% have abnormal bleeding and 51% did have an abnormal coagulation test. The most common site of bleeding were cutaneous in 18%, GI in 5%. Some of the tests that were abnormal, thrombin time, prothrombin time, and PTT, as you can see, 32 to 14%. Subnormal factor 10 levels are seen in about 14% of the patients. And it's not inhibitions, it's really absorption of factor 10 by amyloid. Thrombocytopenia was not common, about 3%. And again, as I mentioned here earlier, acquired Van Willebrand factor deficiency was observed in rare cases. Basically, when we're dealing with factor 10 deficiency, how do we manage that? I think the most important thing is that the factor level matter, and so we should target for a level above 20%. For minor procedure, actually, tranexamic acid or epsilon aminocarboic acid are adequate. But for a major procedure, we should consider prothrombin complex concentrate, factor 10 concentrate when available, and fresh frozen plasma. If you have a very refractory patient who is bleeding, there have been, some report, because where is the amyloid mostly deposit? In the spleen and the liver, and that's where you are absorbing a lot of factor 10. So theoretically, splenectomy may help, but I think maybe that's a little too aggressive. But in very refractory cases, you may need to do that. So my conclusion is that both bleeding and thrombosis are important complications of both AL and ATTR amyloidosis. We need to be vigilant about recognizing these issues and appropriate prophylaxis and measures and needed to, especially before procedure, to reduce these complications and improve the outcome. I think one of the most important things is really we need further investigation to understand the mechanism of these complications. And with that, I turn it back to the chair for moderation. Thank you.